periodontal diseases sends a steady stream of inflammatory molecules like IL-6 and TNF-alpha into your bloodstream. These molecules don't just harm your gums, they damage blood vessels, brain tissue, and metabolism. So one study even found Alzheimer brains full of periodontal bacteria like Porphyrias gingivalis. And yikes, this is actually a study in Science Advancement 2019. So keeping your mouth healthy is directly connected to staying younger and longer. So oil pulling is simple, but surprisingly powerful. Mechanisms of action would be the swishing motion, emulsifies plaque and bacteria, like soap breaking up grease. The antimicrobial effects, coconut oil contains lauric acid, for example, which fights bacteria, fungi, and even some viruses. The anti-inflammatory impact. Studies show oil pulling can reduce oxidative stress and gingival inflammation markers like IL-6 and TNF-alpha. And the microbiome reset. So it helps shift your oral microbiome towards a healthier and less inflammatory balance. So let's look at the data because we like proof, not just tradition. So 2015 RCT by Pediaco, after 30 days of coconut oil pulling, participants had significantly less plaque and gingivitis than the control group. Another RCT 27 by Nagila, dental students who oil pulled had lower plaque scores versus placebo. So as you can see here, oil pulling improves gum health. But again, I don't want to say it's a good replacement for actual dental health. So that's totally different. And chlorhexidine is one of those head-to-head comparisons that was made with this. Chlorhexidine still wins. And in the study of Zhang with 2024, but the thing here is you don't like the staining of the teeth, the irritation of the oral mucosa with chlorhexidine. So that's why oil pulling is another option for that. And how do we do this? Choose your oil first. Traditional Ayurvedic choice is sesame oil, but the modern favorite is coconut oil, thanks to its taste and lauric acid. And however, Ayurveda emphasizes using food natural found in one's environment. So other organic oils like sunflower are pretty okay. So next, timing. Morning on an empty stomach is traditional, or make it part of your bedtime routine if mornings are too hectic. And then what about the amount? It will be 1 tablespoon, so 10 to 15 mils. Swish gently for 10 to 20 minutes when, of course, well, you can watch your Netflix video or YouTube video while doing this. So beginners can start with 15 minutes and then build up slowly. Spit it out into the trash, not the sink, unless you want an emergency call from your plumber. So it's hard to solidify in the pipes and it will clog your pipes eventually. And then finish strong. How? Brush your teeth and scrape your tongue to remove toxins. And they call it in Ayurveda, ama. Ayurvedic tradition favors silver tongue scrapers, but copper or stainless steel works as well. So oil pulling doesn't just freshen your breath, it may even lower systemic inflammation, reduce oxidative stress, and protect brain, heart, and metabolism. Think of it as a low-cost, low-risk longevity hack that fits perfectly into an anti-aging lifestyle. It's not a replacement for brushing, flossing, or dental care, but it's an adjunct tool with ancient roots and growing modern evidence. So that's our leak of the week.
Okay, great. So again, I'll just do a personal note. I had pretty bad plaque. I'd always have the dental hygienist twice a year in there with a hammer and a chisel, um, and hammering away. And so I started doing this. I did a tablespoon of coconut oil, half a teaspoon of turmeric, and a half a teaspoon of baking soda, and that worked really well. I mean, and that the next time I went, they said, "Well, what did you do? You must be flossing a lot." And I'm not a great flosser. I don't like flossing. It's just I don't know, kind of icky to me. um, but that worked really well. And then I have a couple of dentists in our practice here, and I brought it up to them, and they universally said that doesn't do anything. It's no good. Don't even bother. What are you wasting your time for? So take for it what you will.
Well,
Um,
10 to 20 minutes kind of is the
and
challenge here. It has to
that
stay
is a
there for
challenge.
that long.
I don't get it that far. That is quite a challenge. 10 to 20 minutes is quite a long time to be swishing that around and whatnot. Most of it gets swallowed if you try to do it that long. Um, and we're going to hear about exotic. I don't know if you call it exotic. Is Ayurvedic considered exotic? We're going to talk about AI bias tonight and the fact that the AI is biased towards other towards Western medicine. Although lately I've been in my own studies, I've been doing a lot of the deep dives. They have these now, deep research, deep dives. And if I put in specifically, TCM, because that's what I look at, or Ayurveda, it does come up with quite a bit of information on that. So I think maybe if you need to, well, we're going to hear from Dr. James and Dr. Tano, and we'll let them pontificate for us. So tonight we have our Dr. Tano, our specialist and Mr. Brilliant Pioneer, all around Minnesota resident. He's the founder of Integrative Immunity Health System, located in Edina, Minnesota. Johns Hopkins Fellowship trained in allergy, clinical immunology. He's authored a #1 best-selling book, The Layman's Guide to Integrative Immunity. He has a vast experience in allergy, clinical immunology, and in education. I'm just going to leave it at that, Dr. Tano, because I could talk 2 hours about your credentials. And then Dr. Anthony James, who's new to our group, is the Director of Education of NAIC, the Native American Indigenous Church located in Brooksville, Florida, Director of Education and Clinical Services at Missionary Clinic and Wellness Center, founder of and education director of the Soma Veda College of Natural Medicine, Florida Department of Education Commission on Independent Education Authorized Degree Granting Institutions. He's written and published his first book in English titled Nuat Thai, Traditional Thai Medical Massage. Dr. James has graduated over 20,000 students through his Somavada yoga, Thai massage, Ayurveda, and natural medicines. And he's got a credential list as long as Dr. Tano. So I'm going to leave it at that. I'll let the two of you tag team each other and introduce yourselves, if anything that I've missed, so we can get going here. So Dr. Tano, Dr. James, the floor is yours.
Great. Nice to see everyone.
Nice to see you guys.
So, Dr. Tano, do you want to flip forward or do you want to go?
I would let you. I'm going to be just the supporting person here, Dr. James, because that would work better, I think.
Okay.
Yeah.
Well, I was very surprised to hear the tip of the day starts with Ayurveda. So, Ayurveda. I'm a master professor, Achan, of Thai traditional medicine, the traditional medicine of Thailand. I was given that accolade by the Prime Minister of Thailand at one point, recognized by the King of Thailand at one point. I've been a teacher in Thailand for 41 years, teaching Ayurveda to Thai students in Thailand. Like Dr. Clearfield mentioned, I wrote the first book, published in English on Thai Ayurveda.
Dr. James, you're breaking out. I don't know, maybe your audio is not quite clear. I'm not sure.
Can you hear me or
not?
Sorry, let's see if there's anything on my end. Well, I've been on the Zoom all day. It's been working fine, so I guess it's one of those things. Can you hear me now?
I can hear you.
Let me know if you have difficulty hearing me, okay? So back to what I was saying, just as background on this conversation, there's a couple of different points of intersection. One, I did write and publish the first book in English on Thai traditional Ayurveda in 1983. That book, plus 20 others that have followed it, have been used as primary text in Thailand in Thai courses at the college level ever since. As far as Ayurveda goes, right now I'm actually on the advisory board of the largest Ayurveda association outside of India. That's APNA, the Association of Ayurvedic Professionals of North America. I think today we have 213,000 members from 116 countries. We have, of course, many members in the United States at different levels of practice. And our membership goes from entry-level therapists all the way to Ayurvedic doctors and surgeons. And I've received lifetime achievement awards for my Ayurvedic text from Ayush in India and from Agnes. So that's something on the Ayurvedic side. I was happy to see that. And it's going to come into the conversation. The other thing is I'm Native American. And I'm actually the director, one of the founders and director of the Native American Indigenous Church, and we're a federally recognized Native American tribal organization made up of 42 federally recognized tribes. And our mission is to restore medicine to the Native Americans, especially Native Americans that are off-reservation urban. We say urban off-reservation communities, and restoring the practice of natural medicine to Native American communities. It's a daunting task because due to diaspora over centuries, much of the physical practice of Native American medicine was lost, if you will, to history, or it was absorbed into other traditions like osteopathy and like allopathy and perhaps like chiropractic and some others without attribution. And so the physical medicine of the tribes over time diminished to what most people think of as purely ceremonial, not realizing that, for example, just a couple of hundred years ago, there were tens of millions of, maybe 100 million Native Americans in the United States, and they had exhaustive, comprehensive, elaborate physical medicine, medicine for mind, body, and spirit. That's the way we would say it. Which was practiced, of course, at various levels. Some groups specialize more in physical medicine, like the Crows specialized in physical medicine they called pushing, P-U-S-H-I-N-G, pushing. Navajos specialized in emotional, psychological, and spiritual medicine. So what we would call the mental health aspects of healing and medicine. And other tribes had other specialties, and they shared and they worked together to disseminate this information. We know today over 400 different primary medicines that were extracted from indigenous and Native American cultures, South America and North America, were exported to Europe starting in the 1400s, and then were re-imported into the United States in the late 1800s as part of Western medicine, again, without attribution. I'll give you the biggest example that I could name right off the top of my head. There's actually quite many, but most of you have heard of this device used in medicine called the syringe. How many people here have heard of the syringe? This capsule with a hollow needle, which is used to inject substances or extract substances from the body. Anybody? Am I the only one?
Got it.
I think I'm being facetious. I'm not. That is entirely a Native American invention, the syringe. It was invented by Native Americans. It was used widely from North to South America back into antiquity, and it was captured, if you will, by Portuguese and Spanish priest in the 1500s who thought it was so remarkable. They just couldn't believe the applications and how efficient it was as a tool. And they took it back to Queen Isabella, and they took it back to Europe, where it was immediately adopted, and then over time was improved. Okay, until we have, the glass syringe and the metal syringe, and now of course we have the disposable syringe, and we mostly associate with vaccines, but of course they're used for many, many other things than vaccines, right? And I'll describe the syringe to you that was used. Have any of you ever physically encountered a porcupine? I have, but has anybody else in the wild or some other up front you've ever actually seen or been close to a porcupine? You know what I'm talking about?
Yep.
Yes? No? You don't know what a porcupine is? Nobody knows?
I know porcupine for sure.
Okay. They're famous for their quills, right?
Right.
If you're like me and you've lived a lot of your life out in the wilderness, you realize, and you have dogs, okay, you have to be careful because dogs are curious, and if they're out in the woods and they run across a porcupine, well, they want to run up and mess with it immediately. And the slightest touch on the porcupine by the dog, and they have a face full of quills, which you cannot even easily extract. Most of the time you have to use pliers to pull them out. It makes a bloody mess, or you have to take the dog to the vet, and that's an expensive deal. It's almost like they want to charge you per quill to pull those quills out, okay? Well, so they are razor sharp, the quills, and they're hollow. So if you just sand off a little bit of the end of the quill, you have a needle sharp, razor sharp, dagger pointed instrument that is hollow. Now you take a little piece of fish gut or fish bladder, that's the preferred thing, and you put it up, you cut off the wide end, you put the fish bladder over the other end, you take some tendon, gut tendon from some animal, which was a common thing back in the day, and you wrap it around that fish bladder until you seal it and make it really tight. And then you can put that in your mouth, and you put the pointy end in the substance you want to inoculate into the person. And it could be water. It could be a medicament. It could be medicine. There were many, many different kinds of infusions or tinctures that were used. And then you just suck on the bulb, and it pulls, infiltrates the fluid into the syringe, and then you poke that into the client and give it a squeeze. And you are now able to inoculate them with the medicine. And this was a common medicine 500 years ago. Okay, 500 years ago in Native American land. Now, 99.999% of people don't know this. They don't know that when we say Native American medicine, we actually include technologies. They also don't know we have traditional treatments for everything, most of which were lost. Okay, so in the 90s, there were conversations in Native communities about how to restore or create or generate a renaissance in traditional medicine. And there was a sorely lacking of knowledge because so many people who had any knowledge had passed away. So I had the bright idea that because I had this training in Thailand, that I went to the elders and I said, look, why don't we adopt what the UN calls indigenous medicine from tribal people around the world to restore the missing elements of traditional medicine that would have been common to Native communities even as recently as before the Second World War. And they agreed to it, and we created an organization to do that. And my organization is that organization. So to make a long story short, we adopted classical Indian and classical Sri Lankan and classical Thai Ayurveda to replace missing elements of traditional Native American medicine with the blessings of the United Nations and with the blessings of the U.S. government, including the Department of the Interior, Indian Healthcare Association, and so on, with the specific purpose of restoring a holistic, natural, indigenous, tribal medicine perspective to Native peoples, not just in the U.S., but everywhere. And we do work with tribes in many, many other countries. I think right now we have members in 11 countries. So that's where the Ayurveda, a lot of people say, well, where is the Ayurveda? What's that got to do with indigenous or traditional medicine? Under the United Nations World Health Organization, Ayurveda is classified as a indigenous medical cultural heritage. Indigenous medical cultural heritage. And there are many countries in the world that either practice Ayurveda or have some emphasis that's derived from Ayurveda, like aromatherapy, for example, is derived from Ayurveda. Reflexology is derived from Ayurveda. Most Chinese professors now agree that traditional Chinese medicine is a derivative of Ayurveda. And so we have the regional distinctive variations, so on and so forth. I want to give you a little bit of information and why this is important to the AI. One, so I'm going to go to the World Health Organization. I did just a little, I already knew the points, but I want to get the numbers just right for you guys. One of the reasons AI is deficient is at the fundamental level, AI is not programmed to consider indigenous, traditional, regional, geographic, colloquial medicine practices as a general rule. And there are many reasons for this. We sum them up with saying it's an artifact, it's a defect, and it's a bias, which means some of it can be fixed, and we want to recommend some solutions for that. Some of it can be strategically addressed. In other words, learning how to write prompts that allow for conversation that relates to indigenous and traditional medical practices like Ayurveda, for example. But let me give you another reason why it's important, not just in the U.S. The World Health Organization estimates that about 80% of the world's population relies, at least in part, either primarily or at least in part, on traditional medicine practices like Ayurveda. All right, so I want you to think about that. The World Health Organization estimates out of approximately 8 billion people in 2025, that 6.4 billion people in the world today rely on derivatives of classical Indian Ayurveda and or regionally specific traditional medicines. Now, we think, and I've heard this before, Western medical system, best in the world, blah, 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 okay? However, to whatever degree we may claim to be best, we are certainly not the most used medical system. We are certainly not the most relied upon medical system in the world. Not by far. 20% out of the whole world's population having any access to Western medicine at all is actually not a high percentage. I'll give you one statistic from Thailand. The average Thai person, if they have a medical condition, anything, you just migraine headache to cancer, any medical condition, any orthopedic, broken bone, dislocation, inflammatory condition, infection, whatever. The average Thai is 3 days travel time to the nearest Western medical clinic. Once you think, just let that sit in for a second. 3 days to the nearest Western clinic. Okay, the average Indian, 1.3 billion people, could be 3 to 5 days travel time to the nearest Western clinic. The average Chinese person, 1.1, well, you know, a lot of people dispute. They say there's been a big depopulation in China. But let's just say they claim 1.3 billion people. The average Chinese practitioner of any kind, okay, could be a week, 5 days to 7 days travel time just to get a consultation, just to get to the clinic, to physically locate themselves in the clinic. So what do? They're not stacked up like cordwood in the villages. I can tell you that for a fact. I've been all over China, India, Indonesia, Philippines, and so on. And no, there's not bodies in the street stacked up like cordwood. And it's because they're relying on indigenous and traditional medicine, one way or the other, however you would like to call it, traditional Chinese medicine if you're in China, bridging into Southeast Asia, bridging into Africa, growing politic of Ayurveda in Africa. We have many members in Africa now. So what do? Well, they do this functional medicine called principally Ayurveda, or the local variants, which under the United Nations guidelines are called indigenous traditional medicine. Indigenous traditional medicine. Okay, so AI, I have surveyed, myself, I've surveyed 20 different medical AI diagnostic systems. But you know, I'm tricky. I'm cheap. I ask questions where I already know the answer. I'm an Ayurveda professor of Ayurveda, right? So I already know answers. I've written 20 books on it. I already know a lot of the answers that you would hope to get from a medical AI if you ask it to also consider holistic, alternative, or other than Western medical answers. And in every case, the answers were either missing, there was no answer, the answers were incomplete, the answers were not in a correct context, not in a cultural context for the people who would be receiving the treatment. And so, you know, we've got 80% of the world. Now, 20 million of those 80% have migrated, like it or not, into the United States in the last 4 years. 20 million. Okay? That's 20 million people that come from cultures that do not rely on Western medicine, who may not ever have heard of some of the common remedies or treatments in Western medicine. And if all you do is you have a system of AI diagnostics that presents a dominant Western cultural allopathic version of diagnosis, prognosis, and treatment recommendations and protocols, then you disenfranchise automatically that 20%, that 80%. Now, they may not ever say a word to you. You may not know that because you may not have this awareness that certainly in the immigrant populations, but this goes for legitimate immigrant populations as well, like the legal Asian populations in the U.S., the legal African communities in the immigrant communities in the U.S., the legal Chinese. I had an office in Chinatown in Chicago called Golden Lotus, right on Wentworth in downtown Chinatown, Chicago. For 12 years, I was the only white non-Chinese doctor, member of the Chinese Chamber of Commerce for 12 years. And I had clients who had never, they've been living in the US for 20 years and had not had any direct experience with Western medicine. They've been living in and did not speak English, have been living in the US, but they would come to me. Why? Because I could give them access to a traditional medicine protocol that they could recognize. Okay, so one of the problems, now I don't know what we want to say this, it's an insufficiency of data for sure. Okay, it is a bias because the BIOS, the fundamental operating systems of the AI, is written from to cater to a Western medical perspective. The authors and engineers who create the software admit that openly and freely. Okay, and even we have the AIs themselves documenting that this is in fact a fact. Then we have 90% of WHO member states, 90%, formally report that traditional or complementary medicine is in fact the foundation of their national medical systems. Even if they have a Western equivalent FDA and a drug approval process and a medicine approval process for medical practice in the country. How about that? 90%, 9 out of 10 UN countries reported. I know this is, for most Western medical people, it's kind of a shock to hear these numbers. It's like you think it's hyperbolic. It can't possibly be true. Well, go to a general meeting of the UN once or twice, and you'll start to get what I'm talking about. You know, it's quite a mixed crowd. And then we say altogether, Western medicine implementation in the world, it's still best, highest percentages at 61% global population have any access to Western medicine, even if that's what they prefer. And those are going to be mostly people in the major cities like Bangkok in Thailand or Chiang Mai, maybe. Delhi or Kolkata or Ajmer in Coimbatore or Goa in southern India or whatnot will have Western systems. In much of the world, you have this issue of it's called tribal and indigenous. Much of the world is divided up into tribal and clan, and your whole identity of a person in life, even your name, is based on a colloquial tribal identity. Okay, and tribes have preferences for healthcare. Tribes have preferences for healthcare. Pharmaceutical products derived from traditional knowledge illustrate overlap, and that's a game changer. By the way, there's one of your openings. If you can show people that ordinarily wouldn't understand what you're offering, that in fact the medicine that you're recommending to them actually has an indigenous, traditional, native, or tribal origin, they will be more receptive to it. See, one of the issues with AI is that the AI makes a diagnostic, prognosis, whatever, treatment protocol that is alien to the patient and to their culture and to their understanding. They, even if they submit to it, they will not adopt to it. They will not adopt it. And so you're going to have a compliance issue over time. We see that right here in the United States. Indian healthcare under Department of the Interior only offers allopathy primarily on the reservations. And yet, 70% of people who respond on reservations say that they still use traditional medicine And if there was a traditional medicine alternative to what they get at the Indian healthcare clinic on the reservation, they would prefer that. They would do that. And they would do it every time. And there is a compliance issue with people on the reservation because over time they find the Western system to be denigrative of their culture. It's like they don't like it every time they go to a doctor that a practitioner, and I'm not going to say every time, I'm saying what they say. I don't believe this is true. I know, personally, I know some really good docs that are working on reservation and Indian communities today. I do. They're heroic, okay? But I'm talking about what the tribal people say. And the fact is that when they go for help, they don't get healing. They get process, they get protocol, they get drugs. They don't get healing. Forever and a day, indigenous people's medicine was holistic. Holistic like they invented it. So they know it when they see it. They also know the lack of it when they see it. Just calling a procedure non-invasive and holistic to an indigenous person will not convince them that it is so. Because they know what holistic means. They know that real medicine is ethical, moral, and proven. They know that real medicine addresses all aspects of the human, spirit, mind, and body in the context of life and livelihood and family and community and work. And all of those things are considered to be significant. And they're taught from children to believe that all of these things are significant. So even if you have a really incredibly good protocol and you go to present that to the indigenous community, they may tolerate it, but they want a doctor. And eventually you're going to have a compliance issue. And you're also, there were big studies. In fact, one of my students who graduated with their doctorate in indigenous medicine went to Ethiopia and got a really good gig. She was paid by the World Health Organization to go to Ethiopia and do a field survey of the country people, the tribal indigenous country people, who had access to Western medicine from sources like Medicine Sans Frontières, and Doctors Without Borders, and the national government of India, and other, Gates Foundation programs, and so on. They had access to that. Childhood vaccination programs through the Gates Foundation, etc. And her job was to survey compliance. Survey with compliance. What she came up with was extraordinary. Compliance was virtually less than 20% across the board for the whole country of Ethiopia. And this is for free medicine. These people didn't even have to pay. These are NGOs paying for the medicine, paying for the vaccinations, paying for the child care, paying for, and yet they were relying on, quote unquote, witch doctors. See, when I say witch doctor, it's not a denigrating term, because if that's the only doctor within 100 miles and he can fix it, who cares what he's called? They had a similar situation in Madagascar. When COVID hit, there was only a 12% compliance with World Health Organization recommendations for treating COVID, including the vaccines. Over 80% of the population refused all Western medical intervention and relied on the local medicine man or woman and the local tinctures, infusions, herbal remedies that were traditional, and they had a lower mortality rate than the US. Far less compliance, far higher survivability, far lower mortality. We now know this. These are all stats. They feed into this AI thing. Everywhere I look, the AI is being recommended. So when I say, now, bias, I forget who said this in one of the other meetings. Of course, there's some bias here because you have a traditional medicine system that is not documented in a conventional Western way as of today. Now, there are projects trying to remediate that, and bless them, they will be very helpful. So the national government of India, Ayush, has now, in the last 3 years, announced a multi-million, $800 million project to scan and digitize 1 million pages of traditional medical text. Okay, it's a little bit tedious. Why? Those medical texts are written in 500 different languages by hand on wood, paper, sheepskin, and codex made from compressed bamboo leaves on pieces of leather, vellum from the 1850s, and they're attempting to scan these formulas and these documents, and then they have to have specialists from each region who can speak the languages and read the languages, even anachronistic languages. Even there is a body politic of 500,000 medical texts that are written in Pali language, which is anachronistic Sanskrit, the way Sanskrit language was written and spoken 2,000 to 2,500 years ago. The only people in the world today who can read and write and speak Pali are Buddhist monks. They're the only ones. Nobody else can do it. Well, Robert Thurman. I know one guy. I know one guy. Uma Thurman's dad. He can read, write, and speak Pali fluently. So I have to throw him out there. But now imagine, so we have these texts. This is 1,000 years of functional medicine, recipes, diagnostics, prognostics, protocols, treatments, everything from herbal medicine to lifestyle, prayers and meditation, to 500 different surgical procedures written in a language that hasn't been commonly spoken, but yet has been translated into Tibetan, into Gujarat, into Hindi. And so some of the first texts, for example, are called the Charaka Samhita, the Harapika. They have these kinds of names. And a few of them, like 8 of them, 10 of them, have been translated into English. So AI has an issue getting this information and then basically putting it in some context, because a lot of the formulary, which is functional, in other words, it's cured disease, proven to cure disease, proven, okay? Well, it's written in the form of a poem, or it's written in the form of a song. So, for example, there's 1,000 texts about Dr. Quinn's on here. I know he's our expert on CBDs. Okay, well, in Ayurveda, there's 1,000 texts that are written in traditional medical text on the use of the cannabis plant, all parts of it, from the roots to the stems to the brachial to the leaves to the flowers, and at all living states of it, from new sprouts to fully harvested, dried, processed, ground pattern, extracted, tinctured, infused, homeopath. And this body of literature is written in the form of songs, which are called ragas. And they're meant to be sung with accompaniment of a sitar and a tabla. And that's, if you were a doctor of Ayurveda and you were supposed to learn the cannabis cure from a particular school, you had to learn the song. You had to learn the song. I experienced this when I was in India. Did I master this? Absolutely not, Robert. Forget it. Forget it. Enjoy it. Let somebody else take that song, translate it into a written poem, and then interpret the poem into a Western application and sort of understanding. I have to rely on others for that. Now, so this is a daunting task. And right now, AI, in comparison to being able to handle this, is in its infancy. It's not possible. It just simply cannot do it. Okay, so we have this. We have the error of omission. AI omits what it doesn't have access to in the database. We well documented in our book, Decoding AI in Medicine, what we call hallucinatory artifacts, which in medical diagnostics, AI will produce hallucinatory artifacts, including scientific references and citations that don't exist. Literally hallucinate, and they're called hallucinations. Now, how common is that? We don't know. I talked to several different programmers who that's all they do is set up AIs for medical practices and institutions and so on. And I asked them that question point blank: what percentage of the outcomes, generative outcomes for AI diagnosis, may contain hallucinatory elements or improper or made-up citations? And they said they know they're there. They have no estimate what the percentage of that is, but they are there. And so their recommendation, which we put in the book, and I think Dr. Tano also really emphasized, was that if you're going to use AI as a medical tool for diagnostics, it is no substitute for your medical training. It's no substitute for your own personal intelligence and acumen at signs and symptoms and ways and measures and your own, if you will, anecdotal clinical experience. And so Dr. Fong, I wish he was here. He's not here, is he? Dr. Fong mentioned briefly that he was having an issue with med students who were doing exams with AI. And they were actually turning in papers for credit that were generated by AI. And he looked at some of these papers, and the citations that were in these papers, there was no such citation. They were fictitious. And so you had medical students in school submitting papers and case studies for patients that were relying on citations that were fictitious or hallucinatory. And may also, he said, had other issues, which when it came to querying or questioning the students in person, they couldn't actually justify their outcomes, their rationale. They couldn't justify it because they didn't generate it. Okay, so I think there's a lot of possibility and promise with AI. I'm all for it. I am. Okay, but also it's like an unsharpened tool. Maybe there's some chefs here, and you have this experience of trying to cheffery with a really dull knife. You know, trying to chef with a really dull knife, or trying to do some skill that requires a scalpel, a sharp knife, and you don't have one. What you have is really dull. And you have this experience. If it's too dull, you won't be able to do what you need to do at all. If it's just dull enough that you want to try and use it anyway, you're going to get hurt.
Correct.
you're going to get hurt. You're going to cut yourself. You're not just worried about the patient. You're going to cut yourself. Okay, you have to if the instrument's supposed to be sharp, you need it to be razor sharp. If it's supposed to be fine, you need to be really fine. Like I had a microscope that had a defective optic. Have you had that experience? Anybody? They're not 100% perfect, right? Right out of the box. And I thought it was me. You know, I got glasses, right? So I'm just like, it's, you know, the light, the filter, you know, I thought it was me. I had somebody else look at it and they said, no, it's not right. There's something wrong with it. And so I packed it up and I sent it back to the manufacturer, and they were like, oh, my bad, it happens. My bad. But it still even had the inspector, you know, the little inspector certificate with the initial on it. So someone had actually looked at it and didn't see what I saw. They approved it. They sent it to me. I tried to use it. I thought it was me. It was not me. I got a second opinion. Second opinion said, nope, it's not you. It's the optic. It's not right. Okay, that optic is AI. That sharp knife is AI. And we have to double check everything. And then as far as communities, right? It requires the step of identifying if there is a community, if there is a traditional background for the patient, and adding that into your queries. If you don't specifically, just like right now, you're starting to get more responses for Ayurveda. Like we say, well, what might be an Ayurvedic option for periodontal plaque and gum disease? And you get it, and of course in Ayurveda it's called Kavala or Organ Dosa. Okay, Kavala. Okay, but in the Charaka Samhita, the Kabbalah is described as being balancing for the doshas. Okay, so you say, okay, well, I need periodontal. That's what I'm going for. How does dosha relate to periodontal? Well, then when you study the doshas, concept of tridosha, you see that every part of the body relates to a different dosha. And then, who was it that was speaking about the Ayurveda earlier? I'm sorry.
Dr. Nario.
Dr. Nario. Okay. So he mentioned the three primary oils that are recommended. Good job. You were right on the money. Right? Pretty much everything he said was exactly correct. Here's what I would have said. In traditional clinical Ayurveda, as practiced in India today, there's a system to decide which of these oils you use. You have all of them available to the client, and you make a recommendation, sesame versus coconut versus sunflower, based on their what's called Vikruti, which is the difference between Prakruti and Vikruti is the dosha imbalance. So, for example, if you take their pulse and you look at their direct signs of observation, and they are Vata imbalance, that's their primary Vikruti, is Vata imbalance, then you would tell them to use sesame, do not use coconut. If you do the assessment, you take their pulse, you do your direct observation, assessment, and their pitta, you tell them to use coconut. And never use sunflower for this. And if their dosha imbalance, their Vikruti, is kapha imbalance or kapha in Thai, you would tell them to use sunflower and never use sesame or coconut for this. And you would tell them, they would already know they have a Vata imbalance because their overall pathology, spirit, mind, and body. See, it's not just a physical thing. It also is it's a quantification of their attitude. It's a quantification of their overall cognitive facility and inclinations, creative versus linear thinking. It's metabolic inclinations, dealing with like metabolic X syndrome. Are they round? Are they rectangular? Are they triangular in geometric terms? Okay. Now, if you know that, and you want to have this as an integrative approach or as an eclectic complementary medicine approach, then if you had a basic understanding of the tridosha, for example, then you could make a fairly accurate prompt for the medical AI. So what you would do is ask the same query that you did before, and then you would insert for a patient with Vata excess Vikruti. And then just adding those magic words for Vata excess Vikruti, you get a whole nother framework of a recommendation for an herbal procedure, a manual procedure, maybe a meditative procedure. There have actually been studies from the Mahesh Institute. In the past, I was a MAPI certified Ayurvedic doctor through the Maharishi Ayurveda. So they did triple blind studies, and they found out that through meditation, you can change the pH of the saliva in the mouth. You change the pH of saliva in the mouth by literally changing your breath pattern and thinking about it. It's pretty scientifically, triple blind study. So there's a mental, and Ayurveda says this is what Vata means, that it's not just about, I'm going to pull the sesame oil for 20 minutes, which, like, I agree is arduous, not my favorite, okay, but it is a thing. It is quite commonly used. But why Vata? Because it has a peculiar way of addressing a mental state that goes along with the periodontal disease. See, in Western science, maybe we don't know that there is a psychology that can be correlated with periodontal disease. And what we're beginning to find out is that there actually may be mechanisms through these twin, you guys know this better than I do, right? Because you're from everything I know, integrative medicine guys, functional medicine guys, osteopathic medical guys, you know it better than I do, okay? But that there is this psychoneural immunology, and there is this research into hormones and into other factors that may have impact on cognitive function. And bad oral health, periodontal disease, excessive plaque, cavitations, etc., are producing toxins which have an impact on hormones, and those hormones can have an impact on mental acuity and on mental and emotional function. Do you follow me? So in Ayurveda, in these classical native traditions of medicine, they always wanted to have, as part of the picture, in India, it's called the drug picture. I'm not offended by it. It doesn't mean I'm promoting Pfizer. It's just since the 1850s in English in India, the English referred to traditional herbal medicine in India as drugs. So they didn't care turmeric or neem. They didn't care cardamom or ashwagandha. If it was used medically, the English termed it a drug, and that caught on. And today, in the national medical system of India, they refer to Ayurveda medicines as Ayurveda drugs. right? And part of the idea is the practitioner develops what they call the drug picture. And the drug picture is a assessment of dosha and balance, which has direct observation of physical constituents, metabolic testing, even blood testing, pH testing, microscopy, MRIs, whatever. They use that in India today now, okay? But also mental, emotional, familial. In other words, you might say the patient looks fine in 100 different ways, but their family is not right. Their family situation is completely messed up. Now, I don't know if my patient is the one causing the family to be messed up or is the victim of the messed up family. I don't know. But if I was using AI to come up with a complex diagnostic approach, a differential diagnostic approach, I would also throw in the prompt and also in a violent, dysfunctional family, because it will actually generate a different outcome. Because it's also going to attend to things that might have to do with compliance. Because compliant in the office is not the same thing. You know this. Compliant in the office is not the same thing as compliant at home, right? Or in
Dr.
the
James, let me interject here.
Go ahead, Dr. Tano.
Some of the models that are presented for diagnosis are not necessarily conceived by healthcare practitioners. Just like your EHR, your electronic medical record, is conceived by people who know how to do programming. And many of these people, they don't have a logic of flow of how things happen. So when you try to use the EMR, you're stuck because it doesn't flow very well. Same thing for people trying to diagnose things with AI. They tend to put in queries, questions, and then based on the question, they're going to come up with a diagnosis and treatment protocols. But if the query itself is wrong, or whatever you put in is what you get, then in the end, the whole recommendation that is given to you is wrong. So AI bias is, hallucination, we'll call it, but these hallucinations, they're not benign. They can be very dangerous for the patients. So it's very important for someone, even if the company is giving us a diagnosis tool, for us to really vest it and check it, making sure that this tool works very well with patient history. Because a lot of time the AI is based on data that is in the past. So in present, if you put something in there, it doesn't recognize that. Those of you who have used it, sometimes it says, my knowledge goes up to 2023. So my knowledge goes up to 2023. That means whatever the past 2 years, AI has no clue about that. And that all reflects in the data that we're getting. In the end, whatever query you're putting in is not giving you what you want. And we're going to make medical decisions or treatment decisions based on what we put in it. I think that's a big, big bias, and all of us have to be aware of it.
Yeah, and that becomes especially important if you work in, again, this is what Bruce Lee called prejudice of style, because my primary interest and emphasis is in tribal, Native American, and indigenous communities. So in those communities, what we're seeing is the AI medical diagnostic software recommended by the National Institute of Health, Indian Healthcare, for use in clinical facilities doesn't recognize Native American medicine. And it doesn't have a database in there. And so that's something we would like to change. It's a tricky situation, isn't it, Dr. Tano? Because some of these traditions are oral. They've been passed down through generations as oral traditions.
Right.
You might have some recordings of elders from the turn of the century at the Smithsonian. But does AI have access to those recording transcripts from these old recordings of medicine elders at the Smithsonian? And in fact, they don't. Okay. Right now, Smithsonian is actually not allowing these archival databases to be accessed by AI. And I guess they have genuine concerns on proprietary cultural heritage. They have a list of reasons why that is. But on the functional side, we need that information. we need transcripts. We need to decipher these oral traditions into functional applications and formula that we can use today.
So in essence, when they say that AI is going to replace people, in medicine, it's going to be very difficult for AI to replace people, because in order for you to use the AI algorithm that they have, you have to know what you're talking about. And you have to be able to recognize errors that will be made. So if you're not well trained in whatever medicine you're practicing, and you just want to rely on AI, because some people would do that. You already know there are some people who go get diplomas and they call themselves the doctors, but they never went to medical school. I mean, if we had that in the past, now with AI, we're going to get so many people who would practice medicine without license.
Yeah,
because
or
they
try.
they can try. They can say, okay, I have this algorithm, I can just put it in, and then I will get information, and I can treat the patient. But if you have no true training, you may not get what you want, and that could be dangerous for the patients.
I'll give you one I had yesterday in the clinic. Had a client, a patient who's a cancer patient, came into the clinic with 5 pages of an AI diagnostic prognostic protocol, which was completely different from what I would recommend to her and had recommended to her previously. And literally, she wanted me to argue how the AI she shouldn't consider the AI over me, because the AI is, cutting edge.
Yeah.
Cutting edge.
Yeah.
Right. And it was an interesting conversation, but she actually brought it in. I'm glad she did that, because when I looked at it, I could see, I could generally see what the AI was trying to do based on her prompt, right? But her prompt was terrible, right? It was just, what's the best cancer treatment for bilateral multimyeloma organ invasive breast cancer with leukemia? That's it.
Right. So we thought Dr. Google was bad, but Dr. AI is going to be probably worse.
Yeah, Dr. AI. I wanted to see, there was something else. Okay, and we talked about this before, and I want to promote this to you guys, to this group, that you consider the importance of maybe learning a new language for your practice, and that language is AI medical prompt language.
Right.
That you become a master of crafting and articulating prompts for the AI that will dive deep and will consider not just tangible, as in, oh, it was in a clinical trial, but also intangible, wherever that might be available, to give you more of an umbrella or overall approach. Now, you can have other uses for it. I'm not saying this is the only use. I'm just saying, though, we need to actually create a really deep dive course into prompting, medical prompting for AI. Specifically, learn a new language, learn how to speak more precisely. It's just like in the past, you wanted to search up something in the Funkin' Wagnalls. You went by the primary word and you searched for it alphabetically in the Funkin' Wagnalls. It was alphabetically indexed. Yeah, it was 11 volumes, but volume 1 was A, and the last volume was indexed, but it went from A to Z, right? So if you wanted to look for something on zebras, even what's the average width of a zebra's stripe and why do zebras have stripes, you still had to go to Z. And so you would just go to Z. Okay? Well, AI is not like that. AI is not like that. It uses next level Boolean language models, which require you to have layered prompts.
And that is actually correct. I mean, I use AI a lot, but you have to be a very good prompt engineer to get what you want. Because if you just go to ChatGPT and put whatever, okay, give me that, then the hallucinations and all the other problems crop up. So if you really a good prompt engineer and put in the right thing that you want and specifically tell AI to do certain things for you, you may get what you want. It's not all wrong, but you have to know how to prompt it, and that's very, very important. I have looked at AI technology that writes books, and many of those guys, they just, okay, put one line in there and then you get a book. That is completely wrong, because you can get a book, but is that book really something that makes sense? Probably not. In order for you to get a good book out of a good software, you have to be able to prompt it perfectly well. You have to, there are many, many layers that you can put in to get the AI to consider exactly what you want that to say. And when you do it right, it will be as if it's coming from your head and you're putting on the paper because you prompted correctly from what you wanted to get. So
I agree 100%. I want to throw in there 2 points. One, if you're not a software engineer and you think that you can wrangle AI the first time you get on it into giving you the secrets of the universe, you are sadly mistaken, even delusional.
correct.
And there are a lot of people that have a delusional faith in AI outcomes, and they're asking silly questions, and they're getting dramatically silly answers. And they're assuming, because these dramatically silly answers are being generated by the AI, that means there's sophistication in the answer and that it's true. And that's actually not true. So that was one. And the other thing, and I know, Dr. Tano, you're really the best person to do this. Maybe you're the only person. I know 2 people in the world, right, free, who could do this. But you mentioned the term logic flow. And so for the particular patient and the particular issue, the question that's being asked, you have to have a logic flow.
Correct.
And if you want predictable outcomes, that logic flow has to be very consistent.
Correct.
Right? It has to be very consistent.
It has to be consistent. And also, like for a book, you have to be able to reference whatever other chapters have covered.
Correct.
If you don't do that and you linearly say, okay, just give me that, then it will give you information, but not relating.
Yeah.
So it will be repeating itself several times and give you a bunch of information that is not related. But if you reference to previous chapters or previous things that you have done in the prompt, then it gives you something logical that follows just like a human being would be writing it. Yeah.
So, for example, in the overall logic flow of the prompt that you're, so, you know, we're all going to have to become masters of creating a prompt for a particular patient.
Right.
Because that patient is unique like a fingerprint. And if we want an accurate result from the AI, we have to be able to feed the fingerprint into the reader. So that means I'm saying holistic consideration of the patient's issue, of the patient and their issue. And then as far as outcomes on recommendations, if you don't put that you want to consider, for example, in your prompt, integrative health approaches, you're not going to get the integrative health approaches. If you don't put that you also want to look at non-invasive, functional, plant-based equivalent solutions for the drugs that are being recommended, then you won't get the plant-based recommendations.
Right.
And you might have the mistaken impression that they don't exist. And in fact, for many, the plant-based recommendations are far more functional, far more predictable, far less invasive than their drug counterparts.
Okay. So, Dr. James, I think in terms of time interest.
Yeah, sorry, I know.
Let's try to answer some of the questions.
Yeah.
Then people can comment, and everybody's open. You guys can ask the questions, and we can answer those questions, or if anything.
Oh, I made a PDF, Dr. Clearfield. Did you get that on this discussion?
PDF?
Yeah. I was going to say, if you thought it was a good idea, I could put the PDF for the lecture in the...
Yeah, if you send it to me, we can put it on our website. Okay.
I did that already, but I could... No,
okay,
I asked you. No, sorry, I sent it to Dr. Tano.
Okay.
Yes, I'll send it to you. You can have it.
Okay. We'll send it on our website.
Okay.
There's one question really. Is there a database website that allows you to input characteristics that would direct you to a specific meridians? Yeah, I mean, there's a few of them that I know of.
You mean as far as just a database of
Yeah, I think what they're looking for is either symptoms, and it'll come up with a point formula, or even even a Western diagnosis to translate it to TCM, and then come up with some formulations. There's a couple of them. We're doing the CME thing here, so when we're done that, I'll mention the ones that I know.
Right. Yeah, they're still in development. Because here's the thing. So for every meridian imbalance, there are a minimum of 12 variations that are specific to time of day, season, age, and gender of the client. At least 12. So whenever you have a patent, this point for that, even large intestine 4 for headache, most common thing, poster child for acupuncture, right?
Mm-hmm.
Okay, but when you go into large intestine 4 and large intestine meridian, and you start to look at the variables or permutations on using that point, that it's not even about needling the point, that you have 8 different angles that you can put the needle in the point, and you have 4 different depths that you
Mhm.
can put
Yeah.
into the point to whether you're going to affect the collateral, the related, the TSM, the transsubcutaneous
Right.
muscle system. In other words, just for one point, we could do a deep dive and do a whole weekend seminar on large intestine 4. So as far as these online databases, yes, some of them are actually doing pretty good. I think it's a good job generally, right? But nobody's using them to practice. Uh, uh, in fact, acupuncture practice is far simpler than what they show. Where Dr. Burgess, who I see is on this call, I hope he's still here. He's recommended that we recommend or that we promote a very simple system that anybody can do anywhere with literally a couple of hours of training that's based on really no more than about 20 points on about 6 meridians.
And we can do that because it turns out to be an extremely safe procedure, if not one of the safest or the safest in the world.
Yes.
And that's why we can be so open about doing some studies and research on this. It's simple and it works, but it's safe and it's cheap.
Acupuncture is, you mentioned it. Again, what's hard about acupuncture for AI? You had very, very famous acupuncture doctors at the turn of the century who were still alive in the 70s when acupuncture as a practice really came out of China, 1973, Nixon Open China Tour, etc. But there, for example, there was a acupuncture doctor in Japan. His name was Dr. Inoue. He was famous for treating all diseases with one long needle through the navel. Okay, he would use one long needle. Well, when I say long, that needle's like 6 inches long, like this long.
Well, you can do that. Our little group, our ethical research committee, is trying to advance research in this area, and we're welcoming patients to join us in that research.
Right.
So when we expand the homeopuncture, combine the acupuncture with the homeopathy, we can do it with the patient's consent, guidance, and help, because I'm saying we know nothing, but we're trying to do research to find out.
Right. So my point about Dr. Inoue is one needle to cure all disease is complicated. It's not simple. It's not simple. It seems simple. One needle, 1 point, one navel. How hard could it be? But it's like he said in his words, it took him 60 years to work out how to do it. And nobody else really can do it. So we're trying to come up with a real simple system, only based on about 20 points, easy to locate, with about 20 categories of conditions, with a very simple diagnostic that anybody can learn. But back to the AI conversation, this is still beyond the scope of AI. This is beyond the scope of AI. Okay, but understanding clinical applications of points and so on, there's some of this is now showing up in AI, and there's some websites that are pretty good as far as general point remedies or predictors for particular conditions. They're all very, very modern, if you will. So I don't know that I would recommend them. I would occasionally use one if it was some obtuse thing, okay? But for most acupuncture, it is okay to miss the point. No, I'm not supposed to say that. I'm an acupuncture doctor. I'm not supposed to say it. It's okay sometimes to miss the point. Why? Because if you really study Subo and you understand that it's a field of influence, right? And fields can be
that's also why we need to do the research. We have to count how many people we kill by misplacing a drop or a homeopathic or using a certain word. So, but we need to do the research so we really know what's going on here. Because sometimes if it's extremely safe, we have to deal with that issue.
It is extremely safe, and I still haven't heard of or met one person who died from having a drop of a homeopathy on a point anywhere in the world. Uh, uh, I've never heard of that. That's part of why I recommend homeopathy. Is I think, I'm not saying it's perfectly or completely safe because I don't know. I
That's
don't
why
have
we're
any
doing
idea,
research. We're
right?
doing research for a reason.
But
All of us
I
want to
do
know.
say this: other research on millions and millions of patients has been done, and by and large, it's very, very safe. But the point of this, as far as the AI goes, is that because homeopathy has this idea of the determination of miasms as an umbrella choice for repertoire, that is something only a human can do. So you have to be able to eyeball the client. So there are just these artifacts that AI cannot duplicate. AI cannot look at you and say, like I ask you, the client, how are you doing? And you look me right in the eye and you go, I'm fine. Everything's, terrific. But my eye tells me you're sad and depressed.
I think there are many more questions, Dr. James. So, Dr. Clearfield, what have you have a question?
Anytime. So that's what we're doing.
Actually, I don't know. Dr. Narrator, got any online questions?
Yes, I do. So thank you for that great conversation that you guys presented. There is always a question about ethics in relation to using AI. And we all know this, as you guys mentioned, that decision support tools are usually assisted by basically the decision maker. When you mentioned about prompts, which is the human part of this.
Right.
So question was actually, how can clinicians ethically use AI while minimizing harm? So in your perspective, in your studies, in your reading, what are the more ethical, prominent conversations that we need to have here?
Dr. Tano?
Yeah. So, first of all, like I said in the beginning, you have to know what you're talking about. You cannot just go to AI and say, oh, okay, I have this problem. Can you solve it for me? You have to know basically what outcome you will be trying to get before you get the AI to give you something. Otherwise, any Joe Johnson will come and say, hey, I can do AI, now I can solve problems. That's what I was saying. People will go and say, I have a license to practice, when actually they're using AI and they don't know anything about the condition. So for intellectual honesty, before you go and do anything with the AI, you have to know what is behind. You have to know the disease condition or whatever you're trying to do, to making sure that whatever result you get, you can interpret it and be sure that is correct. Otherwise, it's like you are in the zoo and you putting all kinds of things in and it comes out bad and you trust that, then you kill patients and you're not going to do so hard. So
Right.
definitely we have to be very careful. And that's why the prompting engineering comes in. But that alone is not going to solve your problem unless you know what you're talking about.
Right.
I also want to say, same question, okay? The practitioner has to take full and complete responsibility for the outcome.
Right.
And it can't be, I'm not responsible because the AI told me to do it. You have to
Right.
take full and complete responsibility at all times. And also,
Well, they have to anyway, because you're liable if a patient doesn't do well, right?
well, that's what Dr. Font said was the issue. That
You
some of
just
the
sued,
students
then,
had a question that they had this perception that the AI was smarter than them, or knowledgeable than them. So they would defer to the AI in a result. And here's the thing, that's what we don't want.
correct.
We don't want a deference to the AI over the clinician's judgment.
Right. I think that one point here is supposed to be in the future. There should be what we call regulatory audits of these AI systems, meaning a higher power than us probably will do this because there's so many AI generators now
Yes.
that you just don't know which is which. And hopefully one of these days, I don't know how realistic that would be, there will be something that will police that in order for us to really get true information out of these artificial intelligences that are out there.
Right. Well, it'll
And
have to be an AI.
well, AI, it's on an AI, right? So, but
I want to,
another, yeah, go
in
ahead,
our
sorry.
book, Dr. Nario, in our book, we go into that in ad nauseum, the recommendations for regulatory oversight, third-party actors with human moderators who are sophisticated, right? We laid out the possible international, national, even company regulatory type of structures to check and double check what AI is actually generating.
Right. And also, we have to, as clinicians, we have to remember now that AI is getting to be a part of our system. So we have to remember AI scribes are getting used out there. And this is something that also needs to be part of the informed consent of the patient because some of them, they would not be agreeable for them to be recorded during a consult. And because now it's so new, I know practitioners are overlooking this, but in the future and also for the safety of practices, this has to be something that should be observed. I mean, as early as now, we should probably start these have these good habits installed. And as
Well, we have
Dr.
real
Nario,
issues.
I use that daily in my practice. I have this AI scribe called Freed like you free, and
Yeah.
Freed also hallucinates. I mean,
Oh,
when people are talking or you're doing something, it goes off the tangent to write all kinds of wrong things. So if you get the transcribe and you don't go through it and read it carefully, then you have a wrong patient, wrong data that you put it out there, and now your colleagues
That
will
was
laugh
that
at
was what I was talking about before. Generative hallucinations
right.
can be mistranscribed.
Yeah, it does. It does make a lot of mistakes. So you have to read through the transcripts to making sure that it's correct and that all the data you put in, the lab result that you put in are all correct because it just makes up things.
It
so
does
just
make up
another innate.
it makes up references all the time.
Yes, it does.
Yeah,
Right.
I found that one out. So so make sure you check every single reference. In fact, I don't even bother asking them for references anymore because they're wrong more than more than they're right. They make them up and they just don't even exist. So
Right.
I did one where I got like 5 different references, completely different citations, right? And when I opened up each one, they were all the same null page. There were 5 different citations to 5 different studies that when I opened them, it went to the same page, which was a null response and no information. But it was an active link in the citations, and it had a different title for every reference. Okay.
Right.
Are there any other questions?
Yeah, it's a curious question they got. I mean, I'm sure you guys have a lot of reading and experiences with this. Do you have a real world example of AI bias in healthcare? I mean, a specific incident. So this is a question of curiosity, I guess, from
Not
them.
many. I have to pull them up. Dr. Tano, do you have any handy? Do you have the?
So, for instance, for skin diagnosis, like for cancers and stuff like that, whatever is in real life that has been programmed in the AI is what is going to come out. Many times for dark-skinned people, it is very difficult to diagnose cancer. And so if we program in the AI what is the regular diagnosis for the general population that it looks at, like Caucasians and stuff, then if you take African Americans or other people who have dark skin, it may not be able to diagnose it. And that's one really big problem that we have. in terms of bias.
Well, this reminded me of
So,
a
if I could
29.
just interject, one of the things that we found out was because of what Dr. Tano is referencing, that the incidence of misdiagnosis in Africa was 80% higher than in Western latitudes with more fair complexions.
Right.
Right. So this kind of reminded me of a story of a 2019 study in Science that an AI tool was used by U.S. hospitals to predict which patients needed extra care, systematically underestimated the needs of Black patients. As you said, it's becoming now cultural and all, basically in relation to the skin of color. And why? Because it was used for healthcare spending as a proxy for healthcare needs when they were looking at this data. And then historically in this study, less money was spent on Black patients due to disparities because of access. The
Right.
algorithm incorrectly assumed that they were healthier than they were because they were not getting this access to healthcare. So this impacted millions of patients in the African American community. So again, that's why danger is still there. Caution is still should be observed by everyone because we're so young in this technology, and we need heads like you guys to definitely conglomerate to make this even better.
Any questions on prompts or prompt writing?
You can bring it up. I guess those are my questions on my end. Thank you so much.
Can I bring in a couple points? Because, I spend a lot of time with computers. And when I took COBOL, I said, what am I doing up 3 o'clock in the morning, 4 o'clock in the morning, punching cards and programming and compiling? And so what I wanted to say about AI, you have to have knowledge, accuracy, and integrity, but how you the human creativity and artistry in the real sense. And how do you know your intuition is right? And how do you know the AI has correct intuition? So, how do you know that you come up with, say, different protocols and the shoe's going to fit? How are you going to project it? How are you going to project it?
So, Shell, that's what I was saying. You have to actually be knowledgeable first,
Mm-hmm.
and then have AI give you something that you can rely on.
So
If
you got to have experience and intuition, and you
correct,
can't get that just out of AI.
that's right. You have to have
Yeah, track record.
experience and intuition, and then you can use AI as a tool to give you additional information that you need to complement what you have. Otherwise, if you rely just on AI to give you what you want, you may never get that, because if you're not knowledgeable, you're not going to even recognize that what AI is giving you is wrong.
And how's the AI going to know the right thing about individualized diet and lifestyle?
No, you have to prompt it. You have to be able to prompt it and tell it exactly what you want in that.
So I said, instead of punching cards, you get to punch around prompts.
You put in the prompt and you indicate to the AI, I want this specifically for instance, if you say, okay, I would like you to give me a protocol on all the orthomolecular medicine protocols for such thing, disease. And you know what basic protocols are. It will come up with supplement list, and it will give you also the supplement dosing that you need. If you look at it and you know what supplements or these supplements are doing, then you will be sure that this protocol the AI gave you is correct. But
Well, there's probably calibration and dosing too.
yeah, there is. So unless you know that, you're not going to be able to tell. And so if you have no training in functional medicine or orthomolecular medicine, and you tell the AI to give you protocols, it will give you a protocol that you cannot interpret. And so as a result, you're going to use that on patients and it will be wrong.
Well, can AI treat allergies sublingually and know the right things to give a patient?
If you prompt it right, it can tell you dosing, it can tell you all the stuff, sublingual, immunotherapy, all of those things.
But you have the knowledge and experience.
Right, you have to have the knowledge and experience. That's what I was saying.
Yeah.
Some quacks out there, quack, we call them, meaning people who have no training, who would think, okay, AI can give me anything. I'm going to just make it up, and I will have AI to give me protocols that I can use in patients. and those protocols will be wrong, and that is dangerous for the patients. So
Well, it's like a recipe. It can taste delicious, but is it healthy?
that's correct. So you have to be very, very careful and know what you're talking about. Now, by experience, I mean, I do that all the time. When I write books or I do all kinds of things, I make sure that whatever the AI is saying makes sense. Because if it doesn't, you're just playing around.
So let's say when you practice medicine, you do it as an art form because you have the knowledge and experience, right? And can AI create art and the human
It
touch?
does. It can create art, but I mean, you have to get it to create that art for you.
Yeah, but is it art or schlock? You know?
Oh, look at Dr. Tano's background there.
Yeah, look at my background with my key in my brain.
Yeah, the key in the right. So
So, any other questions, curiosities, input,
okay. All right.
output,
Going once, going twice.
prompts?
Thank you so much, Dr. Lewis.
We're doing our prompts here. What's the output?
Okay. All right.
Let me ask a question. Can anybody identify one thing that they were either not knowledgeable of, surprised, or was new for them in this discussion? Just one thing. Was there anything? Or does everybody already know this?
Unfortunately, it's getting late, so many people have left. So the people who were there before.
Yeah.
Okay. Okay. Thank you
Learned
both
something.
for it was a little different, and thank you for your your expertise. Next week we have Dr. De Silva. Derek De Silva is going to be back with us. He's going to be talking about the glycocalyx. So back to medicine stuff. So we met with Kevin Vierlander to work on the website for the conference. If you guys in the research group could get us a speaking list ASAP, so we can get this up and going. I'd like to have it out by a week from Friday. So the sooner you get it, the better. I need a biography of about 100 words, a CV, a picture, and we'll get you a financial disclosure page to sign. And that's what we need from each speaker. We settled on a conference fee for CME for physicians of $695 for in-house, $595 for a virtual, $395 for retired and allied health professionals, which would be nurses, nurse practitioners, physician assistants, and strict homeopaths. $200 for lay people, $250 a day for those who medical personnel, especially if you're getting CME credits, if they're only coming for a day, and $95 for students and residents. And any objection to that? It's the same thing that we charged in 2021. It's the exact same fee schedule. So
There was no inflation here.
yeah, no, that's what we charged in 2021.
Right.
We haven't gone up. And if you've gone, I mean, every conference that I'm looking at is 1,400, 1,600, the ones we want to go to. Even NOMA's 750. And that's pretty generic.
How soon will we have a website we can direct people?
The website's being worked on as we speak. Like I said, we'd like to put the speaker list up. We can put placeholders in between, but that should be ready within 1 week, and then we'll be able to get it out. Okay.
Okay.
So the sooner you can get me your speaker list, and we'll assign times. We're going to give you guys Thursday, mostly. Then the sooner we can get it completed. Okay.
Yep.
All righty. Any questions, any comments, any complaints?
No, I just want to say that I also take some classes with a doctor. He's a yogin. He's a yogin. He tells us so many things. On This is on Thursday, and it's very interesting because he tells us so many other things about structure, water, different things. So uh, yeah, I mean, the medicine and the healing, it's so broad and it can be, uh, it's amazing. I think,
Well, why don't you get us his name and contact, and maybe we can have him on.
yeah, he's so good. And actually, I definitely know that he would like to come. He was also trained to do stem cells from the blood. He said that only 6 in the country were trained by Dr. Ovidio or something like that. I was at the conference with Health Alliance, and then I met him there. And we pay $500, and he does lectures with us every Thursday with peptides, and he tells us everything about the peptides, treatment, ASEA water. So I learn a lot also from him. And it's very interesting because he also has a lot of, like he told us that the way that we sleep in the bed, we have to sleep with the head. I forgot now which direction, because at that time I remember, but now I forgot.
North.
Otherwise, it can affect the energy of the earth can affect our brain, something like that.
I think you have to face north, what I said.
Yeah, you have to face a certain way. And at that time I was thinking, oh, I have to change the way I sleep, but a lot of very interesting things every time.
Okay. Yep. Get me his contact, and we'll try and get him on.
Yeah, Dr.
Okay.
Choksky.
Okay.
Mhm. And he
Okay.
also did a DNA. He has a DNA like Dr. Cohen. He has some DNA that he does. He does genetic and epigenetic coaching too.
Great.
Also something.
And
Okay.
Dr. Clearfield, I sent you by email also a query about a possible presenter also.
About what was that?
I sent you an
An
email
email, I heard.
about a possible presenter that might be exciting for your group.
Okay.
It's a friend of mine.
Okay, great. Okay. Let me make sure I got it. Okay. I'll run it down. Okay. All right, everybody. I forgot the CME credit is 11520. It's always the same. EEDS.com/EM/ and here's the number for this week, 11520. I'll have it in the email flyer for next week. Okay. Thank you so much. I will be sending you the participant list and the video.